Main features of randomized controlled trials. By the end of this presentation, you should understand the definition of the randomized controlled trial, or RCT, know the key elements of the RCT, be able to describe the main types of RCT design. The RCT, or randomized controlled trial, is considered the gold standard of epidemiological study designs. It is the most rigorous method for determining whether there is a relationship between an intervention and the outcome being assessed. In an RCT, study participants are randomly allocated to one of two groups. The strength of this type of study design is in the randomization process. There are several different ways to carry this out. One group of participants are allocated to the experimental group and the other group are allocated to the control group. As with other types of studies, there are key elements in a randomized trial. Firstly, the study hypothesis, which is the research question, is that the intervention is expected to improve health. There has to be uncertainty about this. It would be unethical to carry out a trial when we already know that the intervention is better than the control treatment. The trial objective and outcomes have to be clearly specified. The population being studied has to be decided. For example, is the intervention for older people or children? It is also necessary to have defined eligibility criteria, both inclusion and exclusion criteria, for all participants to fulfill before they take part in the study. Ethical constraints limit what the control group can receive. If there is a standard treatment in use, the control group will have to receive it. By standard treatment, we mean the treatment a patient would normally receive if they were not in the trial. A placebo is only used if there is no current standard treatment. Both groups are then followed up to assess the effectiveness of the intervention compared with the control treatment. The intervention should be at least as good as the standard treatment. What is a study outcome? The outcomes of a study depend on the study question. There are primary and secondary outcomes, and hard and soft outcomes. The primary outcome is the main outcome. This answers the research question. Secondary outcomes are other outcomes, which may include an outcome for a subset of the patients, or a qualitative outcome, such as quality of life. An example of a hard outcome is death. An example of a soft outcome is progression of a disease. Soft outcomes are, by definition, more subjective, as they depend on the investigator who is carrying out the examination. Their definition of progression may differ from another investigator's definition. It is therefore important to use standardized procedures and definitions in any study. Decisions may also be reviewed by a third party. Hard outcomes are better when it comes to analysis, but are not always appropriate for the study. There are different types of RCT depending on whether the randomization is individual or group, and if the treatment allocation is blinded or not. Specific RCT designs include double-blind, single-blind, crossover, multi-factorial, cluster randomized, stepped wedge design. Double-blind RCT. In this design, individual participants are randomly allocated to receive either the intervention or the control. Both participant and investigator are blind to which arm of the RCT the participant belongs. In practical terms, for example for a treatment trial using drops, the container containing both the intervention and control drops would be coded so that it is impossible to tell what each container contains. Single-blind randomized controlled trial. As with the double-blind RCT, individual participants are randomly allocated to receive either the intervention or control. However, in this case, it is only the participant who is blind to the group to which they have been allocated. The investigator will know the allocation. In the crossover trial design, instead of having an intervention group and a control group, participants act as their own control by receiving both the intervention and control treatments. Participants receive a sequence of treatments, one of which will be the standard treatment. The order in which each individual receives each of the treatments is randomly allocated. There's a brief interval called a washout period for each participant between each treatment. This gets rid of the residual effect of the drug. The advantage of this is that the only difference in the groups is the different treatment, because all other characteristics are identical. However, this design is only suitable for trials where the treatment does not have long-term effects. In the multifactorial trial design, 2 or more interventions are compared against a comparison group. The interventions may be applied singly or in combination. For example, to test the best treatment for trachoma, we could compare azithromycin, which is a systemic treatment, against a topical ointment, tetracycline, against the combination of both of them together. This allows investigators to answer more than one research question for a marginal increase in cost. It also allows us to evaluate if there is any interaction between different interventions. Cluster randomized trial. In this type of trial, groups of individuals are randomized rather than single participants. This group is called a cluster, and all members of the cluster receive the same treatment, whether intervention or control. This is often done for community-type interventions where the cluster may be the health centre, hospital or village. It is logistically easier, but there has to be a minimum number of clusters to achieve the same result as individual randomization. Stepped wedge design. In the stepped wedge design, there is a phased introduction of the intervention on a group-by-group basis until the entire population is covered. This method is used in cluster randomized trials when it is ethically difficult to withhold an intervention which will be beneficial. For example, azithromycin treatment for trachoma. When participants are invited to take part in a trial, investigators must explain the trial fully to them, including the risks as well as the benefits. If they are still happy to participate, they must give their informed consent. This can be done in various ways, for example, a thumbprint. The sample size, which is the size of the trial, has to be calculated. It must be large enough to detect the differences you want to see between the 2 arms. In summary, a well-designed RCT provides the strongest evidence that a given intervention is effective and safe. An RCT for a new treatment will always compare the new treatment with the current best available treatment. Blinding within the study design minimizes bias. Double blinding is better than single blinding. Different types of RCT design address different research needs.